Very good evening, everyone. Welcome to iFocus Online episode 330, which is number 5 in the Oculoplasty module. Today we have with us Dr. Suryasnata Rath from LV Prashad Eye Institute, Bhubaneshwar, talking to us on Lagophthalmos, etiologies, evaluation, and management. A very brief introduction about Sir for our audiences. Sir has done his long-term fellowship from LV Prashad Eye Institute after completing his basic medical education from Orissa, and further trained with Peter Dolman in oculoplastics at the University of British Columbia, Canada. Currently, Sir is the campus director, head of education, head of ophthalmic plastic services at LV Prashad Eye Institute, Bhubaneshwar, and also director operations across the LVPI network and the network lead for home care, which was rolled over for the when the COVID-19 pandemic hit us at LVPI. He is member of the executive board, Asia Pacific chapter of the International Thyroid Eye Disease Society, and has authored 67 index publications in peer-reviewed journals and 5 book chapters to date, and is an editor of Surgery in Thyroid Eye Disease, a conceptual approach produced by Springer Publications. He has received the BIRAC Big Innovation Grant and is a project coordinator of the Tribal Orissa Eye Disease Study funded by the Ministry of Tribal Affairs, New Delhi, and also is a principal investigator in the study of the role of infections in the etiopathogenesis of ocular adnexal lymphoma. Well, he's a passionate teacher. A very warm welcome to you, sir, and over to you. We are looking forward to your lecture today.
Thank you so much, Shafali, for a very generous introduction. Let me just share my slides. Just give me a moment. As is usually, I think today's lecture, it's going to be predominantly, as you see, the topic is about Lagophthalmos. And I'll take this opportunity to kind of run you through the basic concept. I believe you can see the slides now, and then I can probably start.
Yes, sir. All okay.
Okay, so essentially, when we talk about Lagophthalmos, I think it's something which is very commonly seen in the clinical practice. While the etiologies can be quite varied, and it's important, like anywhere else in clinical medicine, to actually look at the factors which are responsible for the Lagophthalmos, because I think what is at stake is the vision. Visual function is the most important thing that we are looking out to save in ophthalmology. Amongst the financial disclosures, this is my only financial disclosure, is only partially related to the topic of what I'm discussing today. Now, what is a normal blink? When you have a normal blink, there are several things that happen pretty much in unison. You not only have protection to the ocular surface, but it gets rehydrated and the surface gets washed of all the extraneous substances that get deposited. So a lot of things come in unison, and that's where the blink has a huge role to play. And this blink happens because of the eyelids. If you look at where does exactly the Lagophthalmos term comes from, it appears it is from Greek, and it finds a mention because lagus means hair. And this goes back to sort of a myth that hares sleep with their eyes open. And that's why it's called Lagophthalmos. If we need to look at Lagophthalmos from a 360 degrees, because as I mentioned earlier, what you have at stake is vision and essentially protection of the corneal surface. And as you can see in several pictures here, exposure, superadded infection, particularly in patients who have Lagophthalmos, can be quite sight-threatening. Amongst the etiologies of Lagophthalmos, I think one of the things that it needs mention above any else is the fact that predominantly the closure of the eyes is whenever there is a nerve dysfunction. And we know that the closure of the eyes is to a large extent actually because of the orbicularis oculi muscle and supplied by the facial nerve, which is the seventh cranial nerve. And a very number of etiologies can be responsible for a facial nerve palsy. Foremost amongst them, particularly in a country like ours, remains trauma. Of course, ischemic episodes that we come by can also affect the seventh nerve. And then another interesting, to some extent, idiopathic phenomena is the Bell's palsy, where you have, to a certain extent, in a way, it is help. I mean, it is better because you have a reasonable recovery from it. But if you have a tumor, and particularly quite commonly what we encounter is a tumor in the cerebellopontine angle, the affection of the seventh nerve can cause a significant degree of affection, and most of the time it is something that it does not resolve. So a non-resolving kind of a seventh nerve palsy. There are, of course, infections and immune causes. Again, something which is not very commonly seen, but you can also have a genetic underdevelopment of the seventh and quite often with the sixth nerve. They also say that there could be environmental factors, and this comes under the broad setting of Mobius syndrome, where you actually have a bilateral affection of the seventh and also the sixth. It is said that some of the drugs, I guess some of them which are probably no more used, like thalidomide, and a few others have known to be associated with the syndrome of Mobius syndrome. But the challenge that you face with a scenario like this is quite humongous, and it needs a very aggressive management strategy. When you have a facial nerve palsy, which is one of the predominant causes of Lagophthalmos, I want to show you that there are so many things that happen. And to illustrate that point, I thought it would be best to look at this full face picture of this young lady. We have consent for the full face picture, but I wanted to actually just divide the face in two halves, and you can see the gross difference between the right and the left. So essentially, the point I'm trying to make is muscle tone has a huge role to play in our expressions, in the way we talk, in the eyelid closure, in the position of the mouth, our smile, and so many things. And the reason behind this is multiple set of muscles have a dynamic role to play in each of these expressions. If we were to keep the brow in a certain position, there is a muscle that is responsible as a retractor function, and there is a protractor function, which means that the frontalis is responsible for pulling the eyelid or the eyebrow up, whereas the orbicularis has exactly the opposite. You have a similar function for the upper eyelid in the form of orbicularis trying to close the eyelid, whereas the levator trying to open the eyelid. And the same holds forth for the angle, for the lower eyelid. So we have to keep this in mind, that essentially when you have a dysfunction of one muscle, then a lot of times the treatment lies in trying to take care of this interplay that is affected. That means if the brow goes up, one of the muscles is not acting, and that's because the orbicularis is not acting as well. That's why the eye is going up. So some of the treatment strategies we're going to talk about will deal with this. That's why I want you to keep this in mind before we go on to what exactly can be done. I talked about the lower eyelid, but as we said, since we are ophthalmologists, essentially what really happens is the exposure. And because of the exposure, there are some sight-threatening complications that one has to deal with. Once we have had the etiology of facial nerve palsy, there are several other mechanisms in which, and the most important thing to keep in mind is, if you look at the anatomy of the eyelid in cross-section, we realize that there are just so many layers. There is the skin, there is orbicularis muscle, there is tarsus, there is the levator, there is the Muller's muscle complex, and there is also the conjunctiva. Now, the issue is, whenever you have a cicatricial process in any of these layers, you can also have a lagophthalmos, which we sometimes call as a restrictive lagophthalmos. That means that when you're dealing with a particular layer in a corrective surgery or any definitive surgery, you have to make sure that you need to have enough tissue, enough redundant tissue or enough tissue. And there are clear landmarks to make sure that eye closure is not affected. So this is again something that one needs to keep in mind. And we'll probably deal with a few of these as we progress along this particular lecture. Now, this is something that I've already talked about in the previous picture that I showed. But one thing which I would always take an opportunity is sometimes the etiology of lagophthalmos, it doesn't fall into place when you just look at the eyelids alone. You have a clear corneal surface, usually the inferior 1/3 to 1/2, which has those superficial punctate keratopathy, sometimes coalescing to come even epithelial defects. But you see, there is, when you ask the patient to close the eyelids, there is no lagophthalmos. And that leads you to think what exactly is happening. So you need to keep in mind that sometimes there is a nocturnal lagophthalmos, which may not be picked up. So essentially what I'm trying to drive in is that when we examine a patient in a clinic and ask him for a closure, we need to think not only the number of blinks, whether they are complete blinks. Number two, is the resurfacing of the tears good because the surface is closely opposed? The posterior surface is closely, snugly opposed, which allows this resurfacing. Again, even if it is a complete closure, is it possible that at this point with a voluntary closure, it is happening? But it's possible that the patient is sleeping, there could be another interplay of forces, and that could be responsible for the inferior. So the sleep-associated situation is quite commonly seen in the floppy eyelid syndrome, which you see there, and that's something to be kept in mind. So there is a wide variety of conditions, and what you essentially see as signs and sometimes as symptoms has to be correlated with appropriate questions to really find out what exactly is the etiology. We've already dealt upon two broad categories, and I don't think I need to dwell upon this particular slide that much, but keeping in mind that you have either a predominantly sort of a generational or disinnervation situation because of the facial nerve, or you could also have a cicatricial phenomenon, which is responsible for the lagophthalmos. And there are some scenarios which are beyond that. So essentially the entire evaluation has to deal with that which one amongst them, or is there more than these that you see, which is responsible for the lagophthalmos and the exposure symptoms that you see or changes that you see on the corneal surface. When we talk about the management of lagophthalmos, I think we'll first deal with something, the big elephant in the room, let's say, the facial nerve palsy. Now, I think I would, from over almost a decade of experience, I've sort of simplified this into a very simple algorithm of how exactly should you deal with it. They're just so very common in the clinic. If you have a scenario where you have a patient who has a facial nerve palsy, but has a very good Bell's phenomenon, has a good corneal surface, has no issue with sensations, you could possibly manage this patient with just medical management. We all know that. But how much and where exactly do you intervene? We'll come to a few slides later to really look at. But it's a lot related to the ocular surface that we're talking about. But yes, an intense lubrication, particularly at nighttime ointments, moist chamber glasses, and of course, in situations where very little can be done in the form of a surgical intervention, even a simple eyelid taping, we have seen can protect the surface and can give, at least allow that there is no perforation in scenarios. And we all face with these scenarios very often. So there is a clear role of medical management in scenarios like this. But whenever we see that the ocular compromise, because of the exposure changes are there, one has to think about procedures. And in my armamentarium, I would keep that they are predominantly static procedures or dynamic procedures, a very simple methodology of dividing them. Now, static is whenever you are not doing anything to actually re-innovate the neurovascular complex. Essentially, you have the muscle which cannot function anymore. So all you're doing is changing the position of structures that already exist so that you can either correct the lagophthalmos or improve the ocular surface. That's what I mean by static procedures. Again, static procedures can be various types. I'll deal with that a little while later. You also have dynamic procedures. Now, dynamic procedures are there whenever you can do things to bring in some function back to the muscle. So we're talking about orbicularis oculi function coming back. And that can be done in a lot of techniques, which is either nerve transfers and muscle transfers. And over a period of time, they've actually shown good results. They're promising. So we'll talk a little bit about that. And because that's a very exciting frontier that's there. Now, I talked about static procedures. Let's look at those a little more in detail. When you have static procedures, we have our workhorse to protect, which is definitely tarsorrhaphy. But what really is a problem in tarsorrhaphy? It works great to temporarily protect the surface and help us. And we all know that in situations where you have a very poor or an impending perforation, it does help in resolution of the microbial keratitis. But it is disfiguring. And tarsorrhaphy a lot of times cannot be done for a long period of time for the fact that essentially the patient has concerns that doesn't look very good. So over a period of time, while you may think about doing a tarsorrhaphy protect for temporary purposes, you may have to think more definitive. What are they? I have broadly classified them into upper eyelid and lower eyelid procedures. And I just want you to understand that how exactly do you define that which one would you do for an upper eyelid and which ones for the lower eyelid? Now, essentially, the factors I would think which would help me decide which one to tackle first is pretty much number one is on the time since onset. If I'm dealing with a patient where the hope of a recovery, of resolution of function of the nerve is not something that's going to happen over several months now, I would possibly think about one of the definitive procedures that has to come in. I've already talked about the importance of corneal sensation Bell's phenomenon, but how do I decide between the two? It's very simple. You just have to make sure that you have a very clear understanding of where exactly is the lower eyelid and upper eyelid. And an objective way to measure that is the marginal reflex distance 1 and 2. Keeping that in mind and your lagophthalmos measurements, one can usually decide which one. I can tell you something from experience that more often than not, I have seen that the first procedure that I would go for is actually the lower eyelid compared to the upper eyelid. Because number one, most patients would have a good Bell's phenomenon. If that is the case, if you just pick up the lower eyelid and elevate it, regardless of whichever technique you're doing, as a static procedure, you actually have a significant improvement of the surface. So that's the first procedure that I would go for. And sequentially, if one does not find that that has added to enough benefit, I would actually add on the upper eyelid procedure later on. So that's the sequence in which I'll try to sort of say that much with a few case examples that I have. But I want you to look at the right side, because essentially when you're doing that, for the lower eyelid, there are various techniques that can actually be used. Because as far as the lower eyelid is concerned, you can actually do only a lower eyelid retractor recession. And think of this, essentially you have a facial nerve palsy, which means that there is an interplay of forces where the orbicularis is not functioning and the lower lid retractors have an unopposed action. Keeping that in mind, if you were trying to release the retractor, you would actually have an elevation of the eyelid just by doing that much. You could also add by taking off the lateral horn by augmenting that. And that's been very well reported by Raman Malhotra and saying that that could actually work just as well. We all know that whenever you do something like a lateral tarsal strip, that gives you an advantage of trying to fix the lower eyelid position, but done alone, usually you run the risk of trying to elevate or keep the lower eyelid at an angulation. Honestly, actually, it comes to an advantage because it also helps in the tearing or the epiphora that the patient has. But if you could add a spacer to it, you have a much more normal looking eyelid. And then there are several spacers that you can choose from. In the upper eyelid, there are several things, but essentially you're trying to do a weighting procedure. You're going to use the benefit of gravity to make sure that the eyelid closes well. With that, I think I'm good to move on to. So let's look at this picture and try to see this. Now, this old lady has a right side facial nerve palsy, which has been for several years. And when they came in, these pictures, which are taken in with a digital camera, they really don't show the kind of changes that are already creeping in on the cornea, which are exposure changes. Now, when I look at this picture, how do I decide? All I do is I look at the MRD, I look at the MRD2, 1 and 2. And essentially, when I look at the lag off and also at the position of the lower eyelids, seems like I can benefit the patient much more by trying to do the lower eyelid than I can do the upper eyelid. And that's what I'm trying to highlight, that usually, more often than not, I would actually choose the lower eyelid. And a procedure I chose to do is one of my favorites. I would usually use a spacer of sclera from the eye bank, very easily available, and try to also do a lateral tarsal strip. And this is her position. And you can see the flat position of the lower eyelid. This picture is right after the surgery. So you do expect in a static procedure that you tend to overcorrect just a bit because that's going to fall down. You don't have any innervation or tone of the muscle, but you do that much extra. But what it gives you is a beautiful reduction, I would say, in the Lagophthalmos and much better symptoms. So if I don't achieve what I need to achieve over the next couple of months, I would add the upper eyelid procedure after that. That's what I was trying to say. When I talk about spacers, there are various options of spacers that you can look for. And this is where I would spend a little more time because I think as oculoplastic surgeons, we have a large number of choices to go by. You have autogenous material, and I have highlighted, actually picked out the most common ones. I would think that the hard palate and the nasal septal cartilage have a unique advantage because both of them are composite grafts. They're fairly rigid. They don't contract much. They stay almost the same size. And you have an epithelium or a mucosal covering, which is a huge advantage. When you use sclera, which is commonly what I do, you don't have a conjunctival surface which actually grows over it. And a lot of times you would notice that the sclera actually shrinks in size over a period of time. Having said that, you also have ear cartilage, which can be harvested. You can also use fascia lata, which is more like a hammock because you essentially fix them both to the medial canthal tendon and at the lateral orbital rim at the arcus marginalis so that it works like a hammock. And you could do that with fascia lata. Essentially, any of these autogenous work great, I would say. But there's always a little bit of a hesitancy, I think, based on the fact that you've got to do a second site surgery. And a second site, but I think over a period of time, I would generally prefer hard palate graft a lot of times whenever I want to look at doing this with autogenous material. Allogenic, again, I've talked about sclera if it's available from the eye bank. You can also have human acellular dermis available commercially as alloderm. You have a few choices in the form of xenogenic material also, which is Tarsus and Enduragen. But of course, in recent times, you've also seen a few reports, and I think this one came out from, is what I've highlighted at the bottom, actually. This one came out of Michael Bernstein, and he talks about a very thin sheet of porous polyethylene, which is not really fixed to the lower tarsus. It's only is interplaced between the orbicularis, that means underneath the orbicularis and above the relaxation of the lower lid retractors that you do. And that tends to give a very good results is about a series of 15 to 20 patients that he talks about. And this is an interesting report to look at. So a various choice of materials there. Now let's move to the upper eyelid. If you look at the upper eyelid, you've obviously got a huge thing of weighting it. And traditionally, gold weight implant has been used a lot. The choices essentially, we all know that gold is used essentially because it's of its inertness. You also have a choice of using platinum chains. And of course, you could use hyaluronic acid. Of course, that would give you a certain period of time over which it works, but then it's definitely talked about and reported. One of the things that I want to touch upon is that gold weight definitely has been reported to also be used both when there is a high placement of the gold weight versus a lower placement of the gold weight. And there are some advantages, particularly in the bulge that appears with the gold weight if you're doing a high placement of the gold weight. What is also important is because it's an inert material, to make sure that you actually create a good pocket and over the tarsus and make sure that you have a good skin muscle layer to cover it. That's important because essentially one of the things that you have to always be wary about is exposure or extrusion of the gold weight over a period of time, regardless of what you do. Just a picture to show our own experience. And this particular gentleman actually had Lagophthalmos in both. Essentially, for reasons we do not know, he recovered much better in the right. And the left one started showing changes of exposure. And this is where we placed a gold weight. What I want to see in the closure pictures that we saw at the bottom panel on the right side tend to clearly show the gold weight. And that's the bulge that you notice. But the advantage is the closure is quite good. And though it doesn't come as a very quick blink of a normal eyelid, which I would probably highlight, but essentially as far as the closure of the eyelid, it works out pretty well. This is another patient. And as you can see, the left eye is the one which has a huge lagophthalmos. And based on the lower eyelid positions and the upper eyelid positions, I would take you to the MRD 1 and 2 discussions that I did. And based on also where the right eyelid looks like, I thought the upper eyelid is much better to adduce. So here we've not really done anything, but you can also make out that he's undergone a medial canthal, actually extreme medial tarsorrhaphy. And that's why you've seen a change in the canthus, the way it looks on the inner corner of the eye in the left. So what we did was we usually would test it with several weights, and some of the nomograms that talk about is what exactly you're looking out for. What you're looking out for is what is the weight in which you could induce the minimum amount of ptosis and correct the maximum amount of lagophthalmos. That's what you're looking out for. And usually whatever your test weight, some reports tend to suggest that you can add 0.2 grams to that and go ahead. There's also reports to suggest that sometimes you don't want to go an extensive exercise of trying to do this testing. You could just go with 1.2, and that also works well. This is a picture taken of the same patient for after several months, and you can clearly see the bulge. But what you see is a reasonably good closure. And with the ptosis that he already has because of involutional changes in the right eye, we are pretty good. And these are the things that you want to look at before you plan to do the surgery. One other thing that I wanted to highlight, and is this particular lady where we had also done, is that regardless of the best match that you do, you could end up with a mild ptosis. So that's something which one has to talk to the patient. And also, but this was a lady who had the facial nerve palsy for quite some time. And that's why she was quite okay with it because we had counseled. But that's it. So blepharoptosis is a fine balance between how much you want to reduce it and what's the kind of. The other thing I want to see, that look at the closure. The blink that comes in the right eye naturally is a very fast blink. Look at the blink. Yeah, look at it's really fast. But look at the lower eyelid, the left upper eyelid. It gradually comes. So you have to teach this to the patient, that you have to gradually close your eyes and keep it for a while for essentially for the gold weight action to come in. If you want to make a quick blink, it doesn't help. That's a teaching that has to come in after you do the surgery. Complications, well, you always have complications when you have an implant, and this is no different. One of the most dreaded ones, and I would say somewhere down the line, you're going to face extrusions. So that's something that 5 years, 6 years, a few more years, depending on how they deal with it and how's the surgery, where it's placed, they tend to come out. And that's something you know. So this one came out from the skin. There are reports that they may come out to the conjunctiva too. That's also there. I've talked about the bulge. I've also talked about the implant that is visible, because you may see a shiny streak of gold underneath the skin. That's also seen. Migration, of course, and I've talked about blepharotosis. So these are the things that you need to talk to the patient about before. One of the things I need to mention here is, I think it was Raman Malhotra has actually compared between platinum chains and gold weight implants over patients who have been used it for a fair enough of time. Actually, in that particular report, what came out quite nicely was the fact that platinum chains tend to do much better as far as extrusion. And essentially, platinum is a denser metal, so you have a thinner chain for the same weight. They have beads, but they can be more easily, tucked in underneath the skin muscle flap. And that's why they don't show up as well, and they don't extrude less often. With that, I think we come to the dynamic procedures. And that's, I think, is really something that needs to be explored much more. And that could happen only if we collaborate much more with our colleagues in other departments who do these. Now, how do you decide upon? Essentially, like I said, dynamic procedures are where you breathe. So you're essentially doing a facial reanimation. And it could happen in the form of nerve transfer. It could also be in the form of a muscle transfer. You could have a combination of the two too. But essentially, if we were to decide which one would it be, I think we've talked about the time since onset, because most reports tend to suggest that the nerve transfers work within a period of about 6 to 9 months to a year. Beyond a year, more often than not, the muscle has gone into a disuse atrophy and the motor end plates are not functioning. So even if you do a nerve transfer, it's very high likely that they won't work. So then overall health of the patient is also important. But on the point about the motor end plates being functional, an EMG can usually be done, an electromyogram, and the fasciculations that produces on the muscle can actually help you decide that if they are there, you could possibly still work out with a nerve transfer. If they don't come in as well, then you possibly are looking at doing a muscle transfer, either in the form of a temporalis muscle or some other muscle to take care of, which is functioning in its own place. You're essentially transferring the muscle from where it is to take care of the lagophthalmos. So that's the concept. There's a lot of literature on this, but I think for the constraints of time and our own of what we do, this is something which finds a lot of reference in the recent reports. And this is essentially a situation where the gracilis muscle, along with the obturator nerve, along with its vascular supply, is taken. You have it placed just above or in the layer of the SMAS. But what you do is you're doing two different things. That's why it's called a dual thing, in the sense that you are actually having an end-to-end coaptation of the obturator nerve with a masseteric nerve. So those are the two that you see near the ear in the and that's also shown as an inset. But you also have from the opposite side facial nerve, you have an interposed nerve in the form of a sural nerve, which comes in and gets to an end-to-side coaptation with the obturator nerve. So essentially, the functional gracilis muscle gets its nerve supply in the form of the obturator nerve, which you have harvested, and you have both an end-to-end and end-to-side. Reports tend to suggest that within 4 to 6 months, if you do this, essentially you have a reasonably good facial tone, and you also have good muscle function. So the usual question would be, why would you need to do both? Now, the interesting thing is, if you only do the cross-face nerve graft, which is shown from supply from the facial nerve of the opposite side, you do get a good tone, but you don't get good function. But if you do an end-to-end with the masseteric nerve or the hypoglossal nerve of the ipsilateral side, you're tending to get a good function, which is also the muscle contractions. So the smile and other expressions are much better in addition to the tone. So that's the concept, which is something which is really the next thing. I talked a little bit about nocturnal lagophthalmos, and floppy eyelid syndrome is something that we need to always keep in mind. This was an individual who came in and essentially showed corneal changes. And essentially, when he was closing his eyelids, there was no obvious lagophthalmos. And the next thing, and I think this was just from experience, if you keep on everting the eyelids, you have a feel of how much is the tone in the tarsus. How does the tarsus feel? And all it took me is when the moment I everted the eyelid, I saw there were changes in the right side, which were more on the left side. And you can see the difference of the tarsus undersurface or the conjunctival surface after it has been everted. It was much easier to evert. And interestingly, he moved away. And then I noticed for several blinks after that, his eyelids just did not revert back to normal position. That's a very classic one, actually, of something that somebody who has a floppy eyelid syndrome. They tend to present with a varied manifestation, but essentially the thing that is there is at the sleeping time, the eyelids open up and whatever surface is there, they tend to touch the cornea, leading to changes. We sent him for a sleep test, and sure enough, he came back with a diagnosis of obstructive sleep apnea, and that led to also advice for CPAP and conservative measures. So that's something you always need to keep in mind. But if you were to need a procedure, which is a definitive procedure for floppy eyelid syndrome, it would usually be an eyelid tightening procedure in the form of a pentagon excision or a lateral tarsal strip for correction. Cicatricial changes leading to lagophthalmos in the anterolaminal they're quite apparent, and trauma, accidents, a significant degree of cicatrix is what is there. And these are ones which are quite easy to understand and need correction in the form of full thickness skin grafts or flaps, whichever seem appropriate. And these are pictures to suggest that much. The last part of the presentation is probably dealing with something that's we deal quite often. And in this kind of a scenario, it's essentially changes in the posterior lamina, though not necessarily always, but posterior lamina, which is responsible for the significant lagophthalmos, and that's thyroid eye disease we're talking about. Now, an individual who presented with an active disease, and he had a descemetocele in the left eye and a microbial keratitis in the right eye. Point I'm trying to highlight is we did a tarsorrhaphy to protect the surface in the interim before we actually managed to put him through a bilateral orbital decompression, lower eyelid scleral spacers, and an inferior rectal recession done, made sure that we had the eyes in a better position. And that's him after several months of management with better vision in the left, but he still has a right hypo in the right eye. Another patient, which in the COVID times, a very significant degree of sight-threatening disease. And as you can see, this active patient also had this thyroid optic neuropathy, and she needed, again, bilateral decompression, tarsorrhaphies, eyelid procedures to finally come to a point where she has a functional vision of right eye 20/25. The left eye, of course, we had only achieved a globe salvage and left eye counting fingers vision because of a dense scar. A patient who I had seen many years ago in 2007, severe exposure changes because of thyroid eye disease. And she went through a large number of procedures, I would say. But essentially, the big thing was when we tried to do the orbital decompression, essentially the surface significantly changed. And she's the one who literally asked me to go ahead with the left eye. But the key thing is, I was never aware when we did the decompression that we would be able to salvage some vision in this patient. And she actually had 20/50 in the right eye after a keratoplasty and cataract surgery in the right eye. And we have a follow-up of 7 years for this patient. And of course, this patient who was from the eastern part of the country had a severe microbial keratitis. We did surgery, decompression in a hot orbit. And the point I'm trying to drive in is you need to take care of the proptosis. You also need to keep in mind that the eyelids have to be addressed. If you only take care of the decompression, a lot of times you would see even after decompression, they would go into a microbial keratitis because of the surface changes, because only structural inapposition of the eyelids is not the reason why it leads to sight-threatening disease. That has to be kept in mind. So the eyelids have to be dealt usually at the same setting as the decompression in situations like these. I come to the last slide of my presentation. And this is where I've just talked about that what exactly a very simple algorithm faced with the situation of a lagophthalmos in the clinic. Always look out for signs which would be suggestive of a facial nerve hypofunction. A lot of times there would actually be a partial recovery. So these are very subtle, and you really need to look clearly and for those subtle signs so that you can identify them. Of course, if you have an intact nerve, there are other etiologies that you need to think about. But if it's the facial nerve function we're talking about, you have to decide between medical and surgical. I've already highlighted the importance of static procedures versus dynamic procedures, and which one amongst them in the static procedures are the first ones to go and which ones should be done later. Over a period of time, I would definitely think that the future probably belongs to dynamic procedures. That should be something that should be explored more and more often. If you have an intact, of course, intact facial nerve function, you're looking at a clear psychiatrics which needs to be released, or of course, nocturnal lagophthalmos with the association of obstructive sleep apnea, which needs to be treated, and also the eyelid tightening if it needs a definitive procedure. If I want to leave this presentation probably with something to read about, to explore for all oculoplastic surgeons, I would probably think that look in the lines of dynamic procedures, collaborate with your colleagues, because these are things which you could definitely make a big difference to the life of a patient. And I think that's what I had, and that's my last slide. Thank you so much.
Thank you so much, sir. It was a very stimulating lecture, and lagophthalmos is a very common clinical condition, and all the aspects were covered very beautifully and thoroughly, and specifically the last slide where you enumerated all the points in detail. So it was brilliantly taught, sir. Now, if you permit, sir, we would like to take some questions from different social media portals.
Yeah, absolutely. I would be happy to.
Yes, sir. So the first question, I guess you have already covered it, but pros and cons of gold weight implant versus platinum chain implant.
Yeah, I think that's a good question because essentially, I don't have any personal experience with platinum chains, but from most of the reports that are published, looks like platinum chains do the job better than gold weight. And when I say that, because the weighting effect and the changes or some of the benefits that I showed are there for both. But because usually platinum chains are thinner, or even plates are thinner, and they are easy to tug on the tarsus, they don't show up as well. And the extrusion rates are also better. So that's the report. So I think if you're wanting to use a weight for upper eyelid as one of the common armamentariums in your practice, I think it would be better to explore platinum.
Thank you, sir.
Specific place where these platinum chains are designed, like gold weight, we can go to any jeweler shop and kind of like get it made. But yeah, platinum, does it have like a specific design in any place that is like specifically designing it?
No, thanks, Shafali. Again, that's a very practical thing. And actually, I would think that the most of the manufacturers where you would ask for the gold plate to be coming from, some of them actually have in India available platinum weights too. And they come with the inventory so that you can test it in the clinic very much. I'm not so sure whether in India you have the availability of platinum chains that well. And I think essentially between the two, you could definitely look at platinum weights, which are looks very similar to the gold weights, but they are thinner and essentially do the job better.
Yeah, Ruju, go ahead.
So the next question is, what is the end point of implant surgery?
What is the end point of implant surgery would mean that on the table, what you see, is that what they mean?
Yes, I guess so.
Okay, so I will take it thus that, see, essentially placing an implant is not a difficult job at all. any oculoplastic surgeon would be fairly comfortable. I think choosing the right patient and choosing the right implant, the weight, if you're going with the gold weight, choosing the right weight are the key questions that you need to have in mind. And I think the early part of the presentation talked about how to pick up the ones where you would opt for gold weight over doing a lower eyelid. I would do that every time if the MRD1 is significantly different from the other eye compared to the MRD2. And again, if you have a patient who has a diffuse exposure changes on the entire corneal surface, you want to do something for the upper part of the cornea too. So these are the two things that you want to keep in mind. But if you're faced with a scenario where you have predominant exposure changes, SPKs only in the inferior third or the inferior half of the cornea, and your MRD2 is the more deranged, then you're looking at doing the lower eyelid first. So that's the clarification that you need to have. The second part is if you have a derangement of both, you're probably thinking of either doing them together or you're thinking of at least sequentially doing them. In my practice, I would do the lower eyelid first and then the upper eyelid. So the end point of the surgery, coming back to the question, is doing these decisions correctly, picking the patient with having gone through this exercise, and also picking the right weight is not very difficult, because over a period of time, I've noticed that even if you were to just go and put 1.2 in our group of patients, actually it works pretty well. But you can always do a test before that. It's not very difficult to do.
So may I interrupt you at this point?
Sure.
Yeah. So if you were to combine both the procedures, like doing a gold weight implant as well as a lower lid retractor recession, then how much is the amount of reduction in Lagophthalmos we are aiming at, apart from like when we do the gold weight trial, if I may put it that way? Then we are aiming for a very minimal doses in the primary gaze, and having seen on our trial that there is reduction in Lagophthalmos, the cornea has a good coverage. Is that all we are looking at, or we are looking at complete reduction in Lagophthalmos?
See, I think I'll put it this way. When you're doing a patient in this patient in a scenario where you choose both over one, you're usually dealing with a derangement of both MRD1 and MRD2. Yeah. Number one. Number two, you're also dealing with the ocular surface, which is much more diffuse changes, but not the inferior half, like I mentioned. But the third component is also important. If you were to do a gold weight only, while you give a coverage when the patient blinks with all that I've already mentioned, the patient would still look asymmetric because of the lower eyelid position. So you have to keep in mind that I'll do my test with the gold weight in such a way that essentially at least the eyelid reaches the limbus, the lower limbus. That's something that you have to do in the patient's sitting position, sitting upright, because you want the weight to work. And that's why I said on the table, that endpoint is very difficult. You have to do that before, right? So that's the endpoint in a patient, but the look or the appearance will be far more acceptable if you've addressed the lower eyelid also. If you're doing the upper eyelid, your functional component is better dealt with, but the appearance may be still suboptimal. If you're doing both, I think you end up having a much better look too, which I'm sure the patient would appreciate.
All right. Thank you, sir.
Sir, what is the ideal approach, transcutaneous or transconjunctival approach for implant?
For gold weight, I would say I have always done through a skin approach. And I think there are certain advantages when you do it through the skin approach. Number one would be that essentially you are quite comfortable with the kind of exposure that we do for, let's say, levator surgeries, or a lot of surgeries that we do. And that way, in the conjunctival aspect, while you can still do possibly much a higher placement of the gold weight, but I think the risks would sort of outweigh. So, but I would feel that I'm not in the right position to compare one versus two, like in many other plastic procedures, if people are comfortable from a conceptual point of view, both should work. But I haven't read a lot about the conjunctival exposure and placing an implant with good results to be able to switch from one to another. So I would always prefer the transcutaneous approach.
Okay. And sir, how to assess the amount of LPS recession required?
Yeah, okay. Okay, you know what? If I would just take a liberty to also probably add on a bit to the last question, that a lot of times in plasty, we tend to keep thinking that which approach. I think we should start really focusing on what do we get with whatever approach. Forget about the approach, because we are all surgeons. We all have our comfort zones. We also have, a clear understanding of what is the end point. And whatever way you achieve that end point is important. It doesn't matter whether you go through the skin or whether through the conjunctiva. The next thing is about the LPS recession. For a typical patient with facial nerve palsy, it's not something which I would usually favor that much, because you're inducing a ptosis. But in rare scenarios where the patient, for some reason, does not opt for a gold weight implant, and at the same time, I want to address both, and also if there is already a ptosis of the other eye, I would probably think of doing an LPS recession in the upper eyelid. I've done that a couple of times in addition for the lower eyelid, because that's usually the first one that I would do.
Next question is role of Botox injection in case of Lagophthalmos.
I think that's something which is very relevant, and it's sort of completely not touched upon in what I presented. I think over a period of time, I would feel that it definitely has a very important role. Essentially from the fact that if you try to actually give the Botox injection, I think Milind talks a lot about it. Essentially, if you try to place the injection just transconjunctivally right in the center, which is sort of an anterior position of injection, the chance of the drug diffusing to the superior rectus, which is one of our worries, is very little. So that's where you can get a good, effect of the botulinum toxin in taking care of the it's like a chemo denervation to take care of the Lagoph. I think it works well, but it's not something that one of my choices that much, because I'm always wary about whether I can do just the right bit or more, is usually the worry that keeps me from doing it.
Okay, sir. And a very similar question to this is role of intratarsal steroid injection in case of TED.
That's one of my favorites in the recent times, and we are actually running a prospective study on that. There is a lot of literature in the recent times to show that one of the first muscles to get or sometimes the only muscle to get affected is actually the levator complex. And we keep talking about the inferior rectus and the medial rectus and all that. Having said that, usually patients who have an isolated eyelid retraction, so what we call as an appearance type, it's a good idea to actually do, if possible, an MRI orbit, and also try to bring in signal intensity ratios with T2-weighted images. If you have a clear high SIR ratio, you know that it is the muscle which is not only thickened, but it is active. That means there is active inflammation. That's what the MRI is adding. You already are looking at the sign, which is retraction. So those patients are highly suited to actually try triamcinolone injection. You could do it either transcutaneous, you could do it transconjunctival. The site of injection is very similar. Most patients would give Kenacort 40 milligram per ml, but you would only give about 0.1 to 0.2 ml at that site. The results are quite promising. You've seen a couple of reports which have come out in recent times, and they say that particularly if you're treating a patient in the first 6 months of onset of disease, doesn't have a risk that he will have no other risk factor so that he would have more profound disease over a period of time, most likely does not need decompression because there is no proptosis at all. You only have eyelid retraction, are very well suited to triamcinolone injection. And the reports are quite heartening to start doing them in your practice.
Okay. And what should be the ideal interval between two injections, sir?
Well, that's something which usually you could, because I think also the reports that talk about say that 2 to 3 injections is what you could usually need to do. And most tend to suggest that you could actually go about something between 6 to 8 weeks of interval. Some have talked about a little more frequent, but I would probably be more comfortable giving them a little more time. So you're essentially talking about at least 6 to 8 weeks. That means 1.5 to 2 months between 2 injections, because the effect sets in that much time. How does it work? Whether it is only inflammation it deals with, because the triamcinolone actually acts like a depot there, is something that we don't know yet. But at least from the reports and from the fact that your corroborative finding of imaging MRI tends to suggest that it is inflammation, and that signal intensity ratio after injection tends to subside, is something that is probably just supportive. But you also have the natural history of disease, which is dying out with time.
So I have a follow-up question on that. So in your study, have you seen that the inactive thyroid cases require more injections, or the active ones require, because inflammation is still going on? Like, that's a question I always have in my head, that whether the muscle is so fibrotic that they require more injection, or because active inflammation is going on that they will require more number of injections.
That's $1 million question, because which is it the mechanical effect, is the anti-immunomodulation effect that is working there? But in our study, the inclusion criteria very clearly says that we'll take up patients only the first 9 months after onset of disease, and only if the imaging shows inflammation. So we are actually excluding based on the reports that are already there. So that's outside the scope of what we're doing.
Interestingly, sir, I had a series. I think you were there to judge my posture also. I had more inactive cases where it worked well than the active ones. But I have obviously not done MRI in all the cases, because thyroid, we generally don't go with MRI in all the cases. So, but yeah.
Yeah, but that's exactly what I'm trying to portray all the time, that in medicine, we go a lot with hearsay and what somebody else said. I think we should really look at, so in inactive, if the results are still coming, it's probably not because the steroid is working as against the inflammation there. That's at least not the only way it's working. So we should keep exploring those options for the benefit of our patients. The endpoint.
So I have a follow-up question on this, if I may ask. So comparison between use of triamcinolone acetonide versus botulinum toxin versus fillers in active TED.
Is there I don't know whether there is a head-to-head comparison like that. And if you were to suggest one, it's going to be quite a challenge getting through the ethics for that one. But I think one of the things that is important is, I think we should not really try to put botulinum toxin and triamcinolone in the same bag. The reason I say that is botulinum toxin is actually knocking out the function, and that's how it's working. And it's fairly temporary. So you're not really doing anything for disease modification there. Now, the other two which are there is something that we can pick. My choice would be, at least from what we know, that you should probably think, if the patient is in the phenotype that I talked about, try using triamcinolone, preferably with imaging, in patients who are in the first 6 to 9 months, appearance type. If it is not, you might as well try to do a head-to-head comparison with triamcinolone versus a filler, because both of them would essentially work on the structural component. And that's the kind of a question we should really, really be looking out to answer, because that's a very pertinent question. So sorry to disappoint, I don't have an answer for that, but it's a difficult one.
Is it also that Botox and fillers are more unpredictable, like result-wise, and triamcinolone is slightly like we can?
Not really. I wouldn't say triamcinolone, in my own experience, though I would say this is not a very large number, but in my own experience, I've felt that sometimes even the triamcinolone doesn't work. Now, is that the because the natural history of the disease is overpowering the effect of the drug, whichever way it works, is something that we've not understood as yet. But I think at least the literature tends to go more in favor of the triamcinolone in the recent decade or so. 5 to 10 years, you will see quite a bit of literature coming out. So there's something happening there which needs to be explored.
So also, if I may add to this, if I have a question on this, is there a possible correlation amount, or is there anywhere where we can quantify the amount of triamcinolone acetonide which is being injected in correlation to the thickening?
The first thing most study questions try to deal with is always a binary yes-no. The dosimetry always comes in later. So with the scenario that we have, because you're only dealing with 0.1 to 0.2, is pretty much the the volume that you could possibly inject at that site without not inducing a very obvious change, only because of the fact that you have given a large bolus. It's a difficult one, and eventually I'm not sure whether it will go in that direction to look at the dosimetry. But I think it's a little sort of a premature, because we're still not sure whether it affects most patients that we deal with as far as this is concerned.
Yes, sir. So
one chat question, question from our international audience is there, sir, on YouTube. It's for facial palsy. For lower eyelid retraction in facial palsy, any role of cheek laxity in etiology? It's by Dr. Hen Tan, if I'm pronouncing his name.
That's a very relevant question, and I think it comes. I would answer that when you're dealing with static procedures, you are essentially trying to do an interplay with existing, even if they don't have a innovation supply or whatever structures you have around the area. So whether you do a lower eyelid elevation with a spacer, or you do a mid-face or a cheek elevation, it's actually essentially the same. Over a period of time, I have noticed there are a group of surgeons who don't believe in doing anything for the lower eyelid at all. They always try to do something for the cheek and like a mid-face lift in a traditional approach to take care of the lower eyelid position. And if you think quite, it's not very easy, difficult to sort of differentiate the two. Both serve the same purpose. Probably the mid-face works for a longer period of time, and that's why some don't take care of the lower eyelid. They take care of the entire mid-face in patients with facial nerve palsy. So I think it has a big role, pretty much on the same concepts of the way I explained. But at the end of the day, it is still a static procedure.
Thank you, sir. It was a very interesting discussion, and we thoroughly enjoyed it. So before we call it a day, I have a small announcement to make. Next, we meet on 18th August, that is Friday, and Dr. Ashok Dover will be speaking to us on eyelid reconstruction. Thank you.
Thank you so much, sir, for sparing your time with us today.
Thank you so much.